Hey guys, welcome to our session today. So I'm going to be going over a really quick startup presentation with you guys, just to welcome you, introduce you to our program. If you've not previously attended our shadowing sessions, this might be a little bit helpful to let you know how this works. So pre-health shadowing, if you don't know, we're a student-led, minority-led, women-led nonprofit, and we're dedicated to helping prospective health students and professionals kind of just gain access to educational benefits, no matter their demographic status, abilities, or location. So my name is Shubi. I'm a new chief here on the team at Pre-Health Shadowing. And thank you so much for attending today. So let's get started. So just a little PSA, we do have closed captioning for all of our sessions to accommodate for students. This setting is going to be available on the bottom of your Zoom screen. If you need any help to enable that transcript, let us know. You can DM, direct message one of us on here on the chat, and we can help you out. So we're always looking for more ways to be accessible to every student. So if you have any recommendations for us, you can email us at the email that you see. So since this is an international program, we want to know where everyone is from. So you can drop in the chat where you're zooming in from today, and we'll go through them. We also, if you want to stay in the loop, we do have Instagram and socials like TikTok. You can see our handles here and follow us to see some opportunities or sign up for our mailing list so we can send out emails and keep you updated on all the things that we have going on. So we have some more opportunities for you here. So we've recently launched a research project. So if you're interested in getting research experience, or because of COVID and the pandemic, you've just had a hard time finding PIs and getting into labs, I am really excited to announce that we are launching this program that will allow students to connect with principal investigators and conduct research in a bunch of different topics and locations. So this program is going to be 100% remote, which is really nice. And this means you can connect with anyone. And it's an 8-week program, and we're going to begin hopefully by June 21st. So if you're interested and you want more information, you can fill out the interest form that's sent in the chat, and we can get back to you as soon as possible with more details. So we've also partnered with Kaplan to get our students a 10% discount code that can be used on all of the Kaplan products and free resources as well, such as study guides. This will just help you prepare more for MCAT studying and just standardized tests that you might have to take, for graduate school. So if you do want to take advantage of this, you can fill out our short survey in the chat, and we will sign you up for these deals for free. We also want to draw your attention to our Krispy Kreme fundraiser. We have partnered up with Krispy Kreme to basically get some funding behind PHS, since we are student-led and nonprofit. So what you can do is I think you donate a minimum of $10, but you can donate as much as you want, more than $10 to PHS through that link. And you can purchase a dozen donuts for a donation of $10 for free. So you'll be able to get your treat and help PHS keep functioning. So more instructions can again be found in the chat, and you can click that link to find out more. And really exciting is that we just got PHS t-shirts. So this is another way our organization has been able to get funding and get really nice clothing out to you guys. We have t-shirts, long sleeves, hoodies. This represents, our mission, and it really helps you guys represent PHS. Let's see, and we have Mass for Mass. So this is an organization that is women-led. They donate 4 masks for every 4 masks that are sold. So these really go to people in need during the pandemic, the homeless community, healthcare workers that don't have PPE, and people that are struggling to stay safe. So we have a discount code with Mask for Mask. It's PHS15. You can get 15% off your order. So if you buy through this method, Pre-Health Shadowing will actually also get 10% of the proceeds, which is great, again, since that really helps us run as a nonprofit and get support from our community. And if you are interested in in playing a bigger part in PHS and being part of our team, we have a network of student volunteers and team members. So you can apply to be a part of our administrative team, lead students, or lead initiatives with a bunch of professional outreach initiatives, grant writing, and more. So we really, as a student organization, we know that you might not have the time. So we offer our opportunities that are both asynchronous and synchronous. So you can really accommodate to how much time you have to give to the organization. And again, everything is in the chat and you can check out those links. If you're a high school student and you would like to get more involved, we have a program called HTP, High School Training for PHS. So this lets you connect with college pre-health programs and get a head start. It helps you get involved in fundraising and just get like more resources that might help you as high school students that want to be, future pre-health professionals. So we want to also recognize all the hard work that students give to the program. So if you're interested in getting published, you can submit essays, reflections, research papers, reviews to our editor and chief. So these are all through the link that are dropped in the chat. So these are great just because for CVs, applications, and resumes, this might give you a boost and help you publish some of your writing and, showcase your work. So part of our mission here at PHS is to always promote diversity. And to do this, we've launched an initiative to have monthly panels that celebrate different demographics in the field of medicine. So some of these upcoming events, these include a series of patient experiences, a COVID-19 roundtable, international student forums. So if you have a mentor, professor, or any type of professional that has inspired you, and that you think can contribute to these conversations, you can nominate them by using the link in the chat. And we also humbly ask that you donate to our program. So as you know, pre-health shadowing is completely student run. So we're working around the clock to keep this free and accessible to everyone. So unfortunately, Zoom and our website are not free. So any contribution that you can give would be really appreciated. If you're not financially able to, we request that you send this link to someone that you think can donate and support us keep this program running. All right, so throughout this session, we're gonna ask you to drop any questions in the chat. Our team members are gonna be making a note of these to be asked later in this session. And take good notes because our professionals going over the presentation will also have a post-shadowing assessment to verify your virtual shadowing hours, and you can get a certificate by taking a quiz at the end. And lastly, we want to say to please have your cameras on if you can. This is by no means an obligation, but it does help us feel a little bit closer during this time when social distancing is still mandatory. And we also request that you mute yourself. This will ensure that the professional has a complete and full attention from the audience. So I really appreciate you for listening to all of this. And thank you so much for joining us today. And Dr. Williams, you can share your screen whenever you are ready to go.
Okay. Oops. All right. This went much better in the practice run, but here we go. All right, can everyone see that?
Yes.
All right, great. Hi, everybody. My name is Dr. Allanda Williams. I'm a family medicine resident at Laura Bucks Hospital. I'm so excited to be here today to talk to you guys. This is my first time doing this type of presentation, so bear with me. I do get a little nervous. And again, if you guys have any questions, put it in the chat. I am open to anything, even about life. All right, so I'm gonna start with my slides here. Here are little demographics about myself. So I went to Rutgers, New Brunswick. I obtained my Bachelor's of Arts in Biological Sciences. After that, I went on to get a 2-year master's degree at the Graduate School of Biomedical Sciences that is in Stratford, New Jersey. And I got my master's in Biomedical Sciences. And then after that, Philadelphia College of Osteopathic Medicine, which is a DO school. And I, of course, got my Doctor of Osteopathic Medicine. So let's talk a little bit about just that time in, I guess, undergraduate school, which most of you guys are currently right now. So if there's anything that I wish I could do, if I could go back in time. So obviously the first thing that I would change about my course is the major that I took. Um, I guess I didn't have necessarily a mentor to really guide me through the phases of college. I was the first person to go to college in my family. So in doing that, I took on a science major. And if most of you guys are aware of or privy to, you do not need a science major in order to get into medical school. I would recommend you explore whatever interests you have and just do the prerequisites for medical school. Not to say to change your major now, but I'm just saying that also still is a nice way or a nice path for you to get into medical school. I'm assuming the prerequisites are still the same. You have to do orgo, you have to do biology, you have to do math, you have to do English, as well as, let's see, physics. I have not used orgo since I took the class, just to let you know. But if I was to take an additional class in terms of prerequisites, I would take anatomy. It's very beneficial. I recommend all of you guys take an anatomy class because it's essential to treating a patient. So if you know the anatomy and how things function in the body, you know when things go wrong. And when things go wrong, that's when you decide your treatment options of choice. And so it's easier if you understand how the body functions and you can determine how you would treat the patient. It works out, especially in terms of testing, as well as your clinical knowledge. The second thing I would do over again is take a foreign language. It's such a burden when you cannot communicate with your patient in their native language and require an interpreter. One, it makes the patient encounter longer, and two, things get lost in translation. In other languages, there's multiple ways to explain, a pain or a feeling. So I think two of the most common languages that I've come across would be Mandarin is one, and Spanish. So I think you guys, if you do have the time to squeeze it in, just explore those, options of taking a foreign language. Um, let's also talk about why I went to grad school. So I think it's still the same where you have to take your MCAT during your third year so that you can, start to interview during your fourth year and then start medical school that September. What happened was I was not prepared to take my MCAT at all. I was a part of Audaces at Rutgers, New Brunswick, which is basically it's a group that helps get minority students into pre or professional medical careers. And I was studying, and I didn't feel like I was ready. So I pushed it off a year. And so if you push it off a year, obviously you have to wait the following year to get interviews. And so in the interim, I decided, well, you know what? Let me go to grad school. Let me get my GPA up. Because at that time I was told, you need a 3.5 to get into med school. And at that time, my GPA was probably a 3.2. Um, so I went to grad school. Do I regret going to grad school? I'm just an honest person. I say my mistakes. I don't regret going to grad school because grad school is where I actually learned how to study. Um, and I met great people that helped me and mentored me. What I don't like is the amount of loans that I accrued, at least $60,000 in debt in grad school. So would I do it all over again? I guess I would, it's all a part of the road that I traveled. But again, there is many different paths to medical school. You're going to have bumps along the road. It's okay. Just as long as you have support. And if you need help, reach out for help. I think that's the biggest mistake that students make is that they do not reach out for help when they need it. So I'm going on to my next slide. So why did I choose family medicine? So in medical school, your first 2 years are your didactics, where you're learning all your education, you're sitting in the classroom. The last 2 years, your third and your fourth year, is where you're doing your clinicals. Now, we have a certain amount of required clinicals that you have to rotate through, such as OB-GYN, pediatrics, surgery. I have some listed as well, psychiatry, radiology, medicine, and you have a certain amount of weeks set that you need to rotate through these programs. So when I rotated on OB-GYN, it was the first time I felt like, wow, I could actually see myself doing this. Like, I don't know what it was, but seeing the cervix was really beautiful. It was a beautiful experience for me. I was like, wow, the cervix, I like it. And, delivering babies was also an amazing feeling to, share that moment with families. It is, a once in a lifetime experience. But the downfall of that is, having to be on call. You can't control when someone is going to deliver. And the lifestyle, like you're basically working greater than 90 hours per week. Could I see myself doing that? No. I'm older. I'd like to have a family, and I think I prioritize having a family. So for me, it was just like, it was in the maybe pile, but definitely not the no. And then I, rotated through pediatrics, and essentially I was like, well, I kind of like kids too. So it was really my indecisiveness that made me choose family medicine. I was like, I want both. And so with family medicine, essentially, you can choose the patient population that you want to see. If you want to start from adolescent medicine and see women up till they're 30 or just women and not have, older geriatric population as your patients, you can do that. There's so much flexibility in family medicine that people are not aware of. Again, next bullet point says lifestyle. I don't have to worry about being on call. I don't have to go to the operating room at 3 in the morning. Essentially, my schedule will be 9 to 5 or 8 to 5, but you still have to, fill out paperwork. You still have to do medication refills. You still have those emergency calls sometimes. So it's not essentially 9 to 5, but still it allows me more flexibility. And then the last bullet point is commitment. I didn't want to make a commitment to anything because I was still trying to figure it out. But I still love family medicine, and I feel like it's essentially where I should be. So we get to residency, life of a resident. So family medicine is essentially 3 years to complete. Depending on what specialty you want to go into will determine the length of your residency. You have a call schedule. So call is different according to what residency program you want to go to. So some places have short and long call, meaning you come in at 6 or whatever time the hospital sets for you to come in. Short call would be you leave at 4, long call would be you leave at 6 or 7, and you do the admissions during that time. And essentially also with call, you do 24-hour shifts. So at my program, we come in at 6 and our short call would end at 4. And then you come in at 6 and the long call ends at 6. So you're doing a 12-hour shift in a day. And on our 4-week schedule for medicine, we do 2 24-hour shifts on a Saturday. It's not as bad as it seems. It's doable. So some of you guys' faces, yes, 24-hour shifts. And there is a call room. So if you do need to take a little nap, you can, but you can get paged all hours of the night. So it's nice to have a good team. So I think, when you guys get to that phase of having to interview for different residency spots, you want to take into account, the residents, how happy they are, the dynamic and the personalities of the residents as well. And then, we have our rotations that are set. So for my program, we have to do 4 weeks of critical care, even though we're family medicine, we'll never be in the hospital, but we still have to get through that experience. 16 weeks in pediatrics, we have to do 32 weeks in internal medicine. 28 weeks is elective time, so we can explore our interests. 8 weeks of emergency medicine and 12 weeks of OB-GYN. So I remember as an intern, I was like, why do I have to do so much medicine? I'm in the hospital. I don't want to be in the hospital. I did not sign up for this lifestyle. But now, as a second year going on to third year, I realized how important it is to have all those experiences and understand the dynamics and all the procedures and everything that happens in the hospital. Because when the patient comes to you, they're essentially going to say, what should I expect? And you're going to be the person that has to explain that to them. Or when they get discharged from the hospital, they need to follow up with you within the next 4 weeks. And you ask the patient, like, what happened? They don't know what happened in the hospital. They can't tell you their diagnosis, and they don't come with paperwork. So you essentially have to piece together puzzles. But if you are privy to how the hospital works and what they need to do, then you can help deduce what happened in that time. So oops. So here's all the fellowships that you can go into in family medicine. There is so much that you can do. And as a medical student, I was not aware during my first and second year of the opportunities that family medicine had. Honestly, I'll tell you the truth. When I was in college, I didn't even know the path of becoming an attending or going through medicine. I didn't know what residency was. I didn't know what fellowship was. I was just so unaware. So it's great to have this program for you guys to, open up the eyes of, some of the undergraduate students so that they're more aware of like all the opportunities that they have. You just need to find mentors to help you through this process. Wait, before we get to the case, there's something really important that I wanted to talk about. I was told that most of you guys are like second year, third years in undergrad. So what I'll say is soon, if you're going to be applying to medical school, I think your AMCAS application cycle opens in July. Is that correct?
Yeah, I think so.
All right. So what I would say is you guys need to prepare, have your application and submit it that first couple of weeks in July, because you want to be able to get all the secondaries as soon as possible. And if you submit your secondary early, what I was told is that, you start getting your interviews, you're more likely to get into a school because they don't have the personality developed of the class as of yet because you're in the beginning stages. If you interview later on, then they already have a personality of a class developed. And so you're less likely to get a spot. So just do everything as early as possible. Submit that, primary in July as soon as the application opens up, and then the secondary once it comes in. So by time the middle of August or September, you should start getting invitations for interviews because the interview season, I believe, runs between September and maybe March. And I can tell you for my application and my process, I knew at least by Thanksgiving that I was going to medical school. So you want to kind of get that burden off you. So just do everything on time to have better chances and opportunities, for more, I guess, more interviews. I'm seeing questions here. Am I supposed to be answering questions now or should I wait to the end?
No,
You
you
can
can
wait till the end.
yeah, you can hold
Okay.
them to the end.
All right. So I have a case here, and this was a case that I got on call. I was doing home call. So this is after hours. This is someone calling me at 7 p.m. And it's a 32-year-old female with history of hypothyroidism. And she's coming to the office. Sorry about that. Yes, coming to the office for abdominal pain. Just for completeness, you have the allergies, medications, tobacco, alcohol use, illicit drug use is all negative, but those are always pertinent to your case. So what questions would you want to ask? And then before I say this, are they going to type the responses or can they say the responses?
To prevent an influx of like everyone speaking at the same time, we do ask the students to kind of respond in the chat. And then once that happens, we will have the host relay the response to you. So you won't be having to looking at the chat. We'll do that for you.
All right. So, all right. So I guess what questions would you ask this patient?
All right, so Kelly Annie, she said possibly ask dull or achy pain, and if they can say which quarter of their abdomen. I'm like stuttering. Okay. Nicole asks, how long has this been going for? JC asks, what makes it better or worse? How long have they had the pain? When was the last time she took her Synthroid? Those are some of the questions we got.
Okay, so definitely. You want to ask about her Synthroid. If she's on Synthroid 1, are you taking your Synthroid? How much of your Synthroid are you taking? Because one of the side effects of hypothyroidism is constipation. So could this possibly just be her um, hypothyroidism where she is underdosed and she needs a higher dose? Definitely you want to ask about the quality of the pain, where the pain is, what makes it better or worse. You want to qualify or describe the type of pain that she's having. Is it dull? Is it achy? Is it colicky? Is it is it a stabbing pain? Has it been constant? So those are important questions. Anything else?
Some of the other ones we got were, again, did she take it the medication on an empty stomach? When was the last meal that she ate?
Okay. So this is also a 32-year-old female. So anybody else can think of any additional questions because you have to make it, comprehensive when you're evaluating a patient.
Someone said when her last period was, possibly about
Okay.
pregnancy and
Absolutely.
regular bowel movements. Yeah.
Absolutely. So you definitely want to ask about the type of bowel movements she's having. So you can't really say normal to a patient because they don't know what's abnormal. So can they describe the type of bowel movement? Is it, coming out in pebbles? Is it long? Is it hard? Is it soft? Does it float to the top of the toilet? Are they going to the bathroom every day? Normal might be once a week to a patient, but that's abnormal. That's constipation. So are they having bowel movements every day? The frequency, the color, is it black? Is it brown? Is it bright red? Is it soft like diarrhea? So those are important. Definitely last menstrual period. One big one that you guys missed, but I'm sure you would have gotten it, is like, any history of STDs. Of course, with pregnancy and last menstrual period, they tie in. But when's the last time you had intercourse? And assessing if this is like a chronic abdominal pain or not. So this is how you would, interpret a case, and you would present it the same way. So 32-year-old female, history of hyperthyroidism. She's come into the office with abdominal pain. This is how you're going to present it to your attending. So she has left lower quadrant abdominal pain for the past 2 months, made better by, rest, has been taking in Tylenol Q4 for the abdominal pain. She's never had history of this before, et cetera, et cetera. And then from there, you'll determine your assessment. You want to paint a story. So actually for this lady, I'll just tell you, so she had her abdominal pain for about 2 months, but it's worsened over the past 2 days. It had radiated to her thighs, and nothing seemed to alleviate the pain, even if she was taking medications. She's currently married, so she's sexually active with her husband, but she's saying they're using protection, so there's no chance that she could be pregnant. So at that time, when you're at home, there's a limit to how much you can do for the patient. So you have to determine, like, is this urgent or not? And for me, since the pain had worsened in the past 2 days, it's constant. She hasn't been able to sleep. The only next step would be for her to be further evaluated with imaging. So I recommended for her to go to the emergency room to get a CT scan of the abdomen. And so it turned out she had an ovarian cyst, and that could have potentially ruptured or torsioned. I haven't followed up with her. I'll call and see what she's done, but we did refer her to an OB-GYN, and then they'll just determine the next steps of what they want to do with the cyst, since it's causing so much pain at this point. So history of present illness, again, onset, provocation, what makes it better, what makes it worse, the quality of the pain, dull, achy, sharp, stabbing, radiation, the severity and the timing of the pain. Other things, this is typically how I use it with the OPQRST. That is just the acronym that's easier to remember, but some people just have it generally memorized as it is on the bottom. And this is also necessarily important for billing and coding in the hospital as well. You want to make sure you meet all these points in your HPI so you can get reimbursed for the patient visit. And again, someone said the location of the pain. So all of these differentials are associated with abdominal pain. Of course, it depends on the age, the sex, as well as the severity of the pain. And when you're in the hospital in the emergency room, you want to rule out what can kill the patient first. So you want to ask those pertinent questions. ACS and STEMI can present with abdominal pain. Women typically can present with atypical chest pain with MIs, as well as diabetics. You want to make sure the person isn't having a dissection. Is that abdominal pain radiating to the back? Or AAA, appendicitis, right lower quadrant pain, or umbilical pain that kind of radiated, diverticulitis, left lower quadrant pain. So and this goes back to the anatomy. If you know the anatomy and which organ system is located, it can also help you figure out like the differentials for your patients. So here is another one. I actually can't read this. So 16-month-old, 2-week onset of a blistering rash. I can't read what I wrote because this is kind of covered here. Sorry. Blistering rash that eventually ruptured, has been fussy since rash started, has had decreased appetite. However, he's still having wet diapers. So that's another way to assess if a pediatric patient is dehydrated, is the amount of wet diapers and stools. He is in daycare, doesn't have pets in the home, and the parents deny ever having any similar rash. So anyone can think of like what this rash would be? Or how would they describe this rash?
Susan said measles, maybe.
Okay. What about some descriptors of the rash?
Leslie said, could it possibly be from bacteria, like a bacterial infection?
Mm-hmm. Okay. Guys are getting hot, warm, liking the answers.
JC says raised rash.
Okay, raised. All right. What else?
And someone said viral rash of some sort.
Okay. All right.
Papular, someone guessed.
Mm-hmm.
And scaly as descriptors.
All right, so I would say a key buzzword you would say, and this is a very common rash, is like a honey crusted rash. Scaling over, yes. You can see a cup of bulla still present. So you always want to start with like the size of the rash, the shape, is it irregular? If it's circumferential, is it targetoid? Is the rash purulent? So is there any discharge coming from it? As well as the color of the rash. We do see a lot of macular papular rashes in pediatrics. I would say yes, maybe a little papules are present here. This is really severe for him, but I'll go on and just give you guys what this is. So this is Impetigo. And someone said a bacteria. So it's a very common bacterial infection, typically affecting kids 2 to 5. Very contagious. So you want to make sure, you wash all the kids' clothing, and then as well as taking them out of daycare if they are in daycare. They cannot go back to daycare until they've had like 24 hours at least of treatment. It's typically caused by Staph aureus, but it can be caused by strep pyogenes as well. So the gram positive, gram negative stuff that you guys are learning right now, it all comes back. It never goes away. All right. So if anything, I would learn that really well. And then what you would typically treat is dependent on the extent of the rash. Usually it's smaller. I just put a severe case because I just wanted to a little bit exaggerated, but you would use topical mupirocin cream that usually really treats the rash, and you treat at least BID, meaning twice a day, 3 times a day, for at least about 2 weeks until the rash goes away. And I believe here are some common childhood rashes that we see in the office. Most of them can resolve on their own, and some of them we actually need to treat. So if you guys just want to look through. Ooh, oh, I'm sorry. Don't know how. Oops, nope, doing the wrong thing. Sorry about that. So again, there's a couple of these on the list that you would not treat, but then there's others that you would. So depending on your diagnosis will determine your treatment plan. Pediatrics or kids are really resilient. They can get anything and they'll be fine majority of the time. And I think that's the last slide that I have here. It's my citations here, and then that's it. So
All right. We're gonna see if there's any questions, any more questions in the chat, and then go ahead and ask those. All right, so Kelly Annie asks, for pediatric skin treatment, is it usually treatable in family medicine, or are there other areas where you would refer them to, like a dermatologist?
So for most, okay, so it depends if I want to see children or not. If I am seeing children, then I can treat them in the office. If I've trialed, let's say, maybe 2 drugs or like, let's say something oral as well as a topical treatment, and it still has not resolved, then I'll likely refer them to dermatology because with derm, it's a lot of pathology. So it's always in the path, because sometimes with skin rashes, you can actually, it can look like something, but can be actually mimicking something else. So I would then refer them, if I failed treatment, out to dermatology so that they can have biopsies taken.
Okay. So the next question we have is, Nanda asks, is potassium pomegranate used to treat impetigo? I think that's how you pronounce it.
Potassium
Yeah.
pomegranate.
No, permanganate. That was my fault.
Oh, I'm not familiar with that treatment for impetigo. Typically, the first starting line is mupirocin ointment.
Okay. And then someone also asked, in the case of impetigo, would you rule out chickenpox because of what the rash looks like?
So chickenpox doesn't necessarily have that honey crusted lesions present, and chickenpox is the extent of the body. It's the entire body, and you're going to have vesicles in different healing phases. So with impetigo, it's really usually confined to an area. Typically you see it in the nasal folds. I just gave that picture because the severity, you don't really see it as severe, because typically a parent will come in as soon as they start to develop their rash. So it's usually in a confined area, but with chickenpox, it's an extensive, and they're pretty itchy as well and uncomfortable.
Okay, and then someone asked, what do you think about DO over MD? Is there any stigma based on your experience?
Okay, so I figured I would get that question. There's really no difference between DO and MD. Honestly, it's pretty much the same thing. I would say as a DO, I go through a little bit more training because we have to learn about the muscular skeletal system. So we take additional courses compared to our MD counterpoints. What I would say is I've noticed from patients, maybe I'm a little biased because I'm a DO, that my patients are able to recognize that I'm a DO. They'll always ask me, especially in Pennsylvania, because we have a DO school here. They'll say, oh, did you go to DO school? And I'm like, why? It's just because of your approach. So, we're trained to look at the patient as a whole, which I think everybody, MDs and DOs, should be looking at their patient as a whole in general. But just to answer your question, there is no difference. I have not occurred or had any stigma occurring with having my DO at the end of my name. It's really been a great journey, actually.
That's great. So Kyra also asks, will you be doing a fellowship? If so, in what? And she says, I'm applying to PCOM this cycle. Any tips on how to stand out as an applicant in essays and interviews for that school? And is there anything you wish you could change about the school?
All right. So there's a couple parts to that question. Say it again. Say the first part again.
Yeah, sorry. Will you be doing a fellowship? If so, in what?
Okay, so again, I did want to actually do a fellowship. However, COVID happened. So, during my second year, a lot of the outpatient preceptors were not accepting residents in their office. So we ended up having to do either a lot of education online or hospital rotations. So I didn't get to explore my options the way I wanted to. I think there's a possibility that I may do a fellowship. I was thinking of, possibly obesity medicine or preventative medicine. I'm interested in just like counseling patients on those, like diet, exercise, lifestyle modifications, but I'm not 100% sure yet. What's the second part of the question?
Yeah, so the second part, she says she's applying to PCOM. She wants to know if there's any tips that you have about standing out as an applicant, and if there's anything you wish you could change about the school.
All right, so it's been so long since I interviewed at PCOM. I think the best thing you can do is, be yourself. If there's any red flags on your application, this goes for anybody, just be open about it. Always important to say, like, what have you learned from that experience? If you got an F in biology, if you got a D in orgo, what has that taught you in life? And how can you not, how can you keep that mistake from reoccurring? If you've, extracurricular activities, if you're doing any of that, how does that apply to medicine? Even any of your hobbies, how will that make you, a great, well-rounded physician? So I would flip the narrative like that. Always just be yourself. They can tell you're nervous. They will know you're nervous. Like, I'm nervous right now, but you just have to be yourself and just be open with it. And definitely practice with someone. If you have difficulty with public speaking, then either go to your school, go to mentors, and just have someone interview you and just ask you questions without you telling them what questions to ask. And the second thing would be have someone read your personal statements, multiple people. Okay, I think that's the best bet. And what would I change about the school? So I had a lot of, I would say, some mishaps at PCOM, only because I think the year that I came in, they had changed the curriculum that year. So they were kind of testing out changes. And so, again, I think it was an anatomy class, which I told you in the beginning, take anatomy, because I did not know anatomy. And it was like probably 4 weeks. Yeah, I think it was 4 weeks of anatomy, and we were having exams weekly, and I really was just I wasn't doing great in the class because I was having a hard time memorizing. And at that time, I was used to studying by myself or in a group. But I couldn't find a group because PCOM has 250 students. So it's hard to find a group to study with because everybody is still trying to adapt to learning all this information. I would say medical school is like having a fire hydrant fully open, and the water is all the information coming in at you. And you're just like, what is going on? I have no idea. Everything is happening too quickly. Am I really in medical school? So you're going through all of that. And I think at that time, for the grade to pass the class was a 70, and I got a 69.4. So if you got a 69.5, you can go on. But if you got a 69.4, which I did, then they, they took you out of the class and made you restart the next year. So that's what happened to me. Again, in regards to PCOM, what I would do over again is I would take anatomy. I would take a foreign language class in undergrad to prepare me. That's about it. And I think I would be more open about finding people or other people that are like-minded to study with, and just like initiating that. We had a Facebook page, and I probably should have said, hey guys, this is how I like to study. I need someone who is willing to, go over the terms and their locations, or someone that wants to sit in cadaver lab with me at 12 a.m., 1 a.m., and just review the body. Because that's what I ended up doing eventually, and it worked. Finally, I made it. Any additional questions?
Yeah, thank you so much for sharing that. So I think Megan asked about the rashes. She said, is there ever been cases where a rash has characteristics that can be classified as multiple rashes? And if so, how would you go about distinguishing between the two rashes and just deciding, I guess, your course of action?
So I think what she's trying to say is, if you're ever between two diagnoses for a rash and you're unsure which one is the diagnosis. So in family medicine, we have the way that we would go about it is trial and error. So if you think it's one rash and you're unsure, well, this is recorded, so I don't know. I just want to say this politically correct. You would try a treatment option for the patient. You follow up always within like 3 days. You tell the patient always, if the symptoms worsen or they don't resolve or they don't seem to get better within a certain period of time, please come back or please call me back, and then we'll try something else. So that's typically how we go about treating patients. And again, if you feel like none of your treatment options have worked, then what you would do is you would refer out to dermatology. You would have them go about the route of having some type of biopsy taken so you can determine what the pathology results of the pathology of the rash is, and then you can go about, definitive treatment options.
Okay. Our next question is, Leslie asked, could you share some tips about shadowing doctors in person as a first generation college student?
Okay, so okay. Does she mean during college or during medical school?
I think she means during college, like undergrad.
Okay. So I would say, you always introduce yourself to the doctor. The first day you should always ask, like, I'm a medical school a student. This is what I want to do. What are your expectations? And what can I get out of this learning experience? Because every single doctor has a different personality, and you want to know what they expect you to gain out of that, 2 or 4 week rotation. The second thing is always ask questions. If you don't know, you don't know. But also, you have to do some of the legwork yourself. So, what I would say is, if you see something, we all have our peripheral brains, or our extension of our peripheral brains, which would be our cell phone. So, you can typically Google something really quick. And, if you want to find an answer, and you relay that to the doctor, and then you guys can continue questions. I mean, continue the conversation, as opposed to, what is this? And then they answer the question, and that's the end of the conversation. You can say, okay, you see a rash, and you're like, well, I think this rash is XYZ, and I've seen that they treat with this ointment. How do you determine what you want to treat with, and what would be your first or second treatment? In college, that might be a little more too detailed, but still the point is stimulating conversation for your learning. So ask about expectations, and then always ask questions, and be open you know to feedback from those preceptors, and always introduce yourself to the patients. I think that's very important. I think people forget that. Basic manners go a long way. And these patients are sharing their experience with you. I don't know if you guys have ever gone to the doctor and there's a resident or medical student coming in. It's very invasive sometimes because you want to establish this relationship with the doctor, but then you have someone else that you're probably never going to see again, and they just come into the room and they don't introduce themselves or they don't talk to you. So, be polite, introduce yourself to the patient. And one thing that I've learned that's a great tip is if a patient has an unusual diagnosis, always ask, how did they come about that diagnosis for your learning experience?
All right. So I have a few other questions. So do you have any, oh, sorry, for pediatric skin treatment, is there usually treatable in family medicine? Oh, sorry, you already answered that. Let me look through. Or do you have any ideas on how practicing medicine might change in the future? Kind of a broad question, but.
Yeah, it's complicated. It's really complicated. So, oh man, this is a hard question to navigate. So in the beginning, I know someone introduced themselves as a PA or wanting to go into PA school. So in terms of primary care, you have a lot of what we would consider mid-levels. So that's PAs, nurse practitioners that are, providing preventative care for patients. Essentially, in regards to them providing preventative care, they're supposed to be, overseen or overshadowed by a physician. However, depending on the laws in those states, and yeah, depending on the laws in the states, there's some levels that are petitioning to practice independently without no physician overshadowing. That's one. The second thing is to hospitals. Of course, everything comes down to money. If you have to compensate me $200,000, but you can compensate, a PA or a nurse practitioner $75,000 or $100,000, that's saving in the hospital money. So they would rather go about that route than, having the physician oversee. So you'll start to see a lot of emergency rooms filled with just PAs, and then like primary care with just nurse practitioners. So there's a lot of things changing in politics in regards to medicine. The also essentially we used to see a lot of practitioners having their own independent practice, but it's becoming more difficult to maintain your own practice, especially when insurance comes into play with reimbursement. So that's another way that, medicine is changing. And then to like the amount of time you're spending with patients, having to do everything, document everything on EMRs, really taking away from patient experience. So there's a lot of things that are changing in medicine. So I'm unsure of where it's going to go in the next, 10 to 15 years. You just have to keep up to date with the policies in your state.
Okay, thank you so much for that. So we have one more question from Leslie. This might be our last. We'll try to end around 7:15.
Okay.
So she asked, could you share about what clinical versus non-clinical hours you would need to apply from undergrad to med school? She says, I hear a lot of applicants do so many hours. What would be a good range of hours of experience that you suggest to have when applying?
Clinical hours?
Clinical, I think she means like shadowing near a hospital, scribing, or non-clinical like research, or general volunteering.
All right. So It was a while ago since I applied. When I did apply, I shadowed a pediatrist. That's who I received my letter from. And I think I received my letter also from um, my own personal pediatrician, which I did shadow as well. So in terms of the clinical hours, I did not actually go that route. So I'm unsure. I really can't answer that question. But what I would say is if you can get a job scribing, that could gain you so much experience because one, you learn how to write as a medical professional, even if you don't know the lingo or the words, just hearing it, you're like, okay, chest pain, this is what they ask, you know, radiation, this is like what they treat with. So any medical experience that you can get is always better for you, you know. I have a friend who was a medical scribe, and she would always approach the questions very much different than I, because I was struggling to learn the basics, but she was already privy to, you know, the medical lingo. So she didn't have to deal with those issues because she already knew what they were, the differential or the diagnosis that they were associating whatever the prompt with.
Okay, I think we can do one more question. Was there anything you didn't expect going into family medicine that maybe you were surprised to find out once you started?
Um, I think the biggest thing is insurance and dealing with insurance, how difficult that is. Because I don't want to say they're the bad guys, but they limit a lot of patient care. Um, Sometimes we write for, you know, medications for patients, and essentially what they're saying is, well, we're not going to approve this medication because the patient hasn't failed 2 medications. And we're like, why does the patient need to fail 2 medications? We know this one works. And it's really insurance dependent. You know, some insurances may approve a common medication and another one may not. And the other thing is, what was really surprising is Medicare. Um, for our older patients, how many medications are not approved for them. And they're the population that's going to be taking the most medications. It's unfortunate how insurance companies, you know, direct medical treatment for these patients. So I think that's very unfortunate. And the third thing that I would say is our mental health. So again, this is insurance, how much they do not cover for mental health services. Psychiatrists don't get reimbursed often. So a lot of them are fee for service in terms of seeing those physicians. So patients can't afford $50 a visit or $100 a visit, you know? So I think that was another thing that I didn't expect in family medicine. So as a result, we are often treating a lot of anxiety, depression in the office because patients can't, you know, they can't get a visit for 6 months, or they can't afford to pay out of pocket for that visit. So that was what was shocking, which makes me, you know, sad. It does. It's very unfortunate. We have a lot of people that are struggling, and
Yeah,
we can't service them the way that we would like.
yeah. Thank you so much for all your insight. So that was such an informative presentation. I think we learned so much more about family medicine, about everything related to specialty in general. So thank you so much again. We are going to probably end this by doing a quick wrap up. So I'm
Okay.
going to share my screen. So I have some questions that we can maybe reflect on. So since Dr. Williams gave us so much more information, I would like us to reflect on as participants about what you brought you into the session today. What are some takeaways and what you can go forward with and what you've learned so far. So this writing is reflection is not required, but we do encourage that you submit it to our website for publication of recognition of your hard work. I would also like to mention that once again, pre-health shadowing is launching a research program. We have just launched this, and it's a great way for you to kind of get those non-clinical hours, kind of like we were talking about during the Q&A. So this will allow students to connect with other PIs, conduct research in a bunch of different topics, and it's all 100% remote. So you really have the power to connect with anyone during those 8 weeks. So this will begin June 21st. For more information, you can fill out the interest form that was sent out in the chat. And if you want to get to know more about pre-health shadowing and get involved on our team as an asynchronous volunteer, or if you want to, devote more time behind the scenes, you can check out these 2 links. This is, again, we have synchronous and asynchronous, and we have a bunch of different opportunities for you to get involved with as volunteers. So we are also asking, once again, we're student run and nonprofit. So if you're able to donate, that would be amazing. We have Venmo and PayPal. And this would be great if you could send it out to people if you're not able to, and send out the link. So spread the word about pre-health shadowing and help support us run things on the back end. So now for the part we've all been waiting for. So if you want to earn a digital certificate for attending the session, you can go through these steps. So you can first go on our website, find our professionals course page. You can take a quick 10-minute multiple choice quiz based on the content from the session today. So you'll have about 30 minutes per attempt to earn 70% or higher to get your certificate. So we know that sometimes technology can be difficult, so we do allow 2 attempts for that reason. So if you run into any difficulties, please contact us. And once you've passed, you can click the finish course button at the bottom, download your certificate that verifies your virtual shadowing hours. So if you missed a part of the session, or if you want to go back and watch some of the sessions that you weren't able to attend, then we do have a YouTube channel. So you can go and watch all those recordings. You can find them in the professional page that's on our website, and take the post-shadowing assessments for all of those sessions as well. So be sure to follow us and stay in touch. Sorry, there you go. And yeah, you will be able to look at new upcoming shadowing sessions. You can sign up through our mailing list, look out for them on our social media. And thank you so much for joining us today. Please stick around. If you have any questions, we'd be happy to answer them. So the shadowing session is officially over, and I'm going to stop recording. Thank you so much, everyone. Hope you guys have a great day.